First off, my name is Charles Cook. I'm a two-time transplant recipient of heart in 2016. I received my kidney in 2017. I've been with CDTRP for a little over a year to be a patient. I'm also a member of this year's ASM planning committee. And I want to say thank you, Stephanie, for inviting something that I can do, which is stand in front of the class and read out loud. We have Sylvia Okonofua and Warren Fingrut. They're ready over here on the stage, and I'll be introducing them for their session entitled Advancing a More Inclusive Blood and Transplant System for Donor and Marginalized Groups. First, a little about Sylvia. She's the founder and executive director of Black Donors Save Lives, a federal nonprofit organization that works to engage Black people to donate blood, stem cells, and organs and tissues. She's also a donor recruiter with Stem Cell Club. In these roles, Sylvia has worked for the past 7 years to overcome unique barriers to donation impacting African, Caribbean, and Black communities in Canada, and advocate for Black patients in need of life-saving donation products. Now on to Warren. Warren is an assistant professor at MD Anderson Cancer Center, who specializes in addressing healthcare disparities in stem cell transplantation and cellular therapy. He was also an MPH student at Harvard and the founder of Stem Cell Club, a not-for-profit organization that aims to tackle racial disparities in stem cell donation access.
Thank you so much, Charles. It's great to be here. Thank you so much for the CDTRP for the opportunity to present today. My name is Sylvia Okonofua. I'm the Executive Director of Black Donors Save Lives. And today I'll be presenting on a topic entitled Advancing a More Inclusive Blood and Transplant System for Marginalized Groups. I'd also like to thank my mentor, Dr. Warren Fingrut, for his guidance throughout this project. I have a relevant conflict of interest to declare today. But just as an introduction, according to panelists as health advocates, physicians need to work with communities to improve health. They need to determine and understand the needs, keep on the health of others when required, and support mobilization of resources in health needs. However, health advocacy skills are challenging, and recent research is called for a need to develop curricula in health equity. So that's what we've done. We developed a human medicine health equity curriculum entitled Advancing a More Inclusive Blood and Transplant System for Marginalized Groups. This curriculum has two modules as part of this. The first one we titled Building a More Inclusive Blood and Transplant System for LGBTQ+IA peoples. And in this module, we address blood, stem cell, and organ and tissue donation in Canada for gay, bisexual, and other men who have sex with men. We outlined all the historical policies, how they came to be in the first place, and in relation to today's policies and where future policies may lie. The next module that makes up our curricula is addressing racial disparities in blood, stem cell, and organ and tissue donor pools. And in this module, we address disparities in donor pools across donation products. We highlighted some of the barriers to donation impacting racialized and ethnic populations. And we also talked about structural racism in donation policy. So I'm going to start with the first module, which is building a more inclusive blood and transplant system for LGBTQ+IA peoples. So as part of our module, what we did was we discussed the history of gay, bisexual, and men who have sex with men in terms of their blood donation in Canada. So what we started with was we talked about how the blood system in Canada came to be in the first place, in the history of in the blood donation criteria for men who have sex with men. And the system was set up in the aftermath of the tainted blood scandal, which was a blood management catastrophe, with tens of thousands of Canadian blood recipients were infected with HIV and hepatitis C. So to prevent that tragedy from happening again, Canada's blood system was redesigned to prioritize donation safety, to prioritize patient involvement as well as blood supply. However, these priorities did not include or even consider health equity. So as part of our module, we explained frequently asked questions, not only by gay and bisexual people, but everybody. Why is screening testing needed? Like, we're already testing the blood for HIV and other infectious diseases. Why are you asking me about sexual orientation? Why are you asking me if I've ever been to Africa, for example? So we explained that these blood tests can't detect rainbow-fluid infections. And these refers to the time where a person who has an infection, that blood cannot be detected for such infection during that window period. So we explained that multiple levels of safety are used into the Canadian blood criteria in order to prevent patients from being infected with HIV or hepatitis C again. Next, we discuss changes. How are they made? And why are they taking so long to change? So on the left, we talked about the blood donor eligibility criteria. It started from 1977, where we had that lifetime deferral introduced. Up until now, in 2022, where we have the gender neutral criteria introduced. We also talked about some other donation methods and donation products, the stem cells. So since 2009, gay, bisexual, and other men who have sex with men have been eligible to donate stem cells and organ and tissue donors. Organ and tissues. So I guess I'm pretty excited. But then again, it makes you wonder, why is it taking so long for the blood criteria eligibility to change from 1977 up until now? So we did go over those talks. The first one was grassroots advocacy. So they need to be a grassroots advocacy, being the pivotal driving force for such change to happen. So what that does is it highlights the need for improvement. And what they end up doing is it goes to the blood operators. So Canadian Blood Services, Team of Quebec, they review the donor eligibility criteria and potential changes. They gather data that helps to support on the need for donation safety, the need for the maintenance of blood supply, as well as patient accountability. And as you can imagine, all of this takes time. So to gather data for all of these three facets takes years, takes time, takes resources. So they have all these data now. What's the next step? The blood operators, they create a proposal, send it to Health Canada to be able to make these changes. So Health Canada receives a proposal, what's next? So Health Canada decides whether to allow the change based on the presented evidence. So, we kind of showed the process of change here, and I think it helps participants appreciate how long and tedious this process can be. So the next thing we did was highlighted some of the unique barriers to donation. So what we did is we had a focus group of 37 gay and bisexual men, all between the ages of 7 and 35, and some from non-European ancestral groups. And we identified some barriers to donation, one of which was lack of knowledge. So they just weren't aware that they were eligible to donate. With someone saying, I didn't even realize they didn't really donate stem cells. Another barrier to donation we found was exclusion from blood donation. So primary exclusion from blood donation poses a barrier to them wanting to donate stem cells. When someone says, I sort of feel like I'm being left behind, and I feel like a second-class citizen, and even if I do want to go donate now, I don't feel like it anymore. You excluded me before, I don't want to do this anymore. Another barrier we found was misuse of the healthcare system. From participants saying they've had so many negative experiences in the past that at this point, we just don't trust the system anymore to do their favor. Still on the focus group information, we also found some key facilitators to donations. That was really interesting. And some of the facilitators to donation we found was education materials that show that gay, bisexual, and other men of sex men are wanted, are needed to participate. So we showed multimedia that we created in collaboration with members of the community. And we had participants voicing that these videos, these multimedia resources help them to feel included and not feel insignificant. Another key facilitator of the donation was reassurance. Gay, bisexual, and other men who have sex will be treated well. So we have a video from a doctor actually as part of our multimedia collection that in that video, if I remember correctly, he was just reassuring people, like, don't be afraid to go to the hospital, you're not going to be treated differently. And participants responded to that. They said that reassurance helped them out. It helped them feel like they're not going to be judged for the agenda, for their sexual orientation. And the third facilitated a donation was diverse representation. So they want to see people from the community, a vast array of people from the community, voicing out that, hey, donation is okay, like, it's okay for you to like, they said, well, I've done it before, it's, you know, this is getting better. So they want to see spokesperson from their community advocating for such change. So the next thing we talked about was collaborating with advocates for justice disparities. And we rolled out our Saving Lives with Pride campaign. And this country is really feels wide array of multimedia resources. We have infographics, we have videos, testimonials from members of the community from different parts of the community. So we're pretty heterogeneous when creating the multimedia. We have stories and podcasts from gay, bisexual, and other men, bisexual men, donors, recipients. We have statements from Transplant hematologists. And the purpose of this was again to reassure. The purpose of this was to collaborate with the community, to have someone from the community say, hey, it's okay, this is what I've done before, this is what I received stem cells, and this saved my life, and stuff like that. So what we did was we also did quantitative analysis of the feedback that we got from these focus groups. And we learned that by viewing this multimedia, there was improved knowledge. So people who didn't really know a lot about stem cell donation, who didn't know a lot about organ and tissue donation, were pleasantly more aware at the end of the session. We have lower ambivalence to donations in terms of attitude. People are more likely to entertain the idea of donation after viewing more resources. Participants also said by viewing the multimedia, they have reduced barriers to donation. We're more willing to donate if we call it time. Next, I'll talk about the second module, which we titled Addressing Racial Disparity in Blood, Stem Cell, and Organ and Tissue Donors. So the first thing we did in our EOE module was stated diverse donors are needed across donation products. In the case of blood, there are ethnic differences in minor blood antigens, in the RH variants, in ducting expression, for example. And there are guidelines that recommend extensive phenotype matching. All of this to prevent allogenization. But if you think about it, everything here requires ethnic donor population. In the case of stem cells, for example, your racial disparities limit access to 8 out of 8 unrelated donors. In the case of Black patients lack 8 out of 8 unrelated donors, and those who do go on to receive 8 out of 8 unrelated donors, for example, they either have older donors or delayed time to transplantation. And in the case of organ and tissue, compared to White patients, Black patients are 50 to 70% less likely to receive kidney transplantation. So what else did we talk about? What's another problem? Of course, that diverse peoples are underrepresented as donors. In Canada, Black people make up around 4% of the entire Canadian population, but around 1% of blood donors and only 1.5% of potential stem cell donors. And you might be asking me, Sylvia, where's the stats for organ and tissues? We don't have it. Maybe one day we'll find that. The third part of the online module talks about the diverse problems that diverse people face in relation to donation. For example, among sub-Saharan African immigrants, they just didn't know. Someone said, when I was living in Africa, I just never thought of it. It never really crossed my mind. And there was this need for approval from family, from community leaders, posing as a barrier to donation. And obviously the historic mistrust, the historic medical mistrust and misunderstanding. For example, Black Canadians of African descent, they believe that they're either ineligible to donate blood, or even if they do want to donate blood, either their blood is not wanted or will be discarded if they go to donate. Next, we highlighted structural racism in donation policy being a barrier to donation. So what is structural racism? The American Medical Association defines structural racism as a totality of ways in which societies foster racial discrimination through mutually reinforcing systems. So we see structural racism in patient eligibility for transplantation. We see it in donor eligibility screening questionnaire. We can even see it even in Canada here, the historic deferral of African ancestry donors due to HIV or malaria. So all of this has been done where we prioritize patient safety without even considering health equity. And then we also presented an example of ongoing discrimination, donor discrimination. So this is an excerpt of a 2019 donor health screening questionnaire. This was authored by an international multi-institutional task force with the purpose of screening donors for behavioral risk factors for infectious diseases. So I want to bring your attention to two questions here that highlight discrimination against African ancestry donors. The first question says, have you ever had sexual contact with anyone who's born in or live in Africa? Have you ever been in Africa? And questions like this exacerbate mistrust and contribute to structural racism. It interferes with efforts to address disparities. And frankly, there are many countries like this, many countries with similar questions like this, in terms of blood donor screening, stem cell donor screening. So what needs to be done? There needs to be an acknowledgement and a way to address past and present exclusion to overcoming these barriers to inclusion. So just like the previous slide of Sylvia Okonofua, we developed a campaign which is now a non-profit that I lead called Black Donors Survive. So again, just like before, we have all the multimedia resources that we created in partnership with advocates from the community. And we also did quantitative analysis of the feedback from these focus groups where we found improved knowledge, lower ambivalence to donation, as well as improved barriers to donation. From both these modules, we have facilitated discussion groups. And in these discussion groups, we have the participants to reflect on the need for diversity of donors and the barriers to donation in practices of the population. Some of the questions we asked was, what are the reasons for disparities in blood? What are the reasons for disparities in stem cell, organ, and tissue donor pools? What historical events played a role? And what healthcare policies contributed to that? As part of the discussion here, participants were also able to review and share examples of structural barriers in donation. They also discussed how to advocate better for diversity in donor pools across donation models. So our curriculum pilots and evaluation focused was hosted at 9 Canadian medical schools. We had 142 med students as participants, 62% female, 46 identified as racialized or LGBTQ plus IA, and 83% were in pre-closure years. And for each of these workshops, we had a subset of medical students that participated in focus groups to share their perspectives. And qualitative analysis identified rich examples of participants' development as health advocates across these 5 themes. One of the themes highlighted would be prioritize inclusion, recognizing discrimination, understanding barriers to change, collaborating with advocates from diverse communities to address disparities, and building a culture to support inclusion. Now, I'd like to go over some of these themes and provide some representative quotes from our participants. On the theme of highlighting the need to prioritize inclusion, participants saw that it was our duty, from the medical field. We saw it as their duty as stewards of the system to help prioritize inclusion. Participants also recognize the need for diversity in the population, diversity across donation product. And this is really interesting because participants understood diversity from blood donations, diverse blood donors, but they never really understood up until now for the need of diverse stem cell donors, diverse organ and tissue donors. That was pretty exciting for me at least to see. On the theme of recognizing discrimination, participants were able to recognize discrimination in policies and in practice. This first participant said, it's just weird to me that you could just paint an entire community in one brush. And in terms of recognizing discrimination in practice, the race-based GFR calculation for human classification was one, practice that kept coming up over and over in our discussion groups, where participants highlighted, and that was a clear example of how racism can play a role into people's access to much needed donation products that are limited supply. And on the theme of understanding barriers to change, this first one was really interesting to me because participants were like, I understand why it's like rigid. I understand it, I appreciate that, and it makes me feel safe. At the same time, this system is oppressive and stigmatizing, and it's also very slow to change. Participants also saw that having lack of diverse healthcare professionals to champion this change for specific communities acted as a barrier to change. And on the theme of addressing disparities in collaboration with advocates, participants wanted someone from their community who shared their perspective, shared their shared struggle, to be able to champion this change, to be able to speak on behalf of others. And this concept of nothing about us without us kept coming up a lot, where participants said, you can't just go ahead and fix someone else's problem or what you think their problem is. You need to understand it from the point of view, and that was really, really interesting to see. And the last theme was building a culture to support inclusion. And, participants were, we're actually put in a process where they have to reflect. With participants saying, I've had previous patients before in the past, and this is forcing me to go back and think about the previous encounters I've had, the statements on the questions I asked them, and really think about how that's impacting the patient's perception of the healthcare system, and whether it's acting as a barrier or genuinely positive work. This was really interesting to me, and we're still beginning on this, and at this point, I'm going to pass it on to Dr. Warren Fingrut for the breakout session.
Thank you so much, Sylvia. Evaluation as well, and the impact on the medical students, but piloted it. So based on the work that we've done so far and our analysis of feedback on medical students, we generated these 5 themes. We saw some really powerful quotations from what the medical students took away from it. And it got us thinking, preparing for this workshop, these are themes that are relevant to our community as well. And so how can we explore these more fully together, not just with the content that we summarize and put together, summarized based on the modules, but also with experience and practice and lived experience with this cohort and share. So based on that, we prepared some guiding questions for each theme. And we'll split everyone, first of all, for the virtual groups, just your instructions are that you'll be divided into 2 different groups, and each group will discuss one theme. And so you can already go to your breakout rooms and we'll look forward. And then at the end, we'll all come back for a wrap up where everyone, every group will have a representative on to the podium or to have a microphone and to share some of the key learnings from a group that discuss the takeaways. And so you can go to the virtual groups and go into that. And then now for the in-person folks that are here, I'd like to ask that you divide the groups so something like 5 to 7 people. They will come around and assign each of you with some guided discussion questions. And so go through the questions together as a group, reflect on your experience, and discuss it together. And Sylvia and I will walk around, and then at the end we'll all come back together and share our findings as a group. Very good.
All right, so I'm from theme 1. And we had a couple of questions here for discussion. First question was, what does it mean to prioritize inclusion? So we talked about all voices being heard, measuring who is included. So actually making sure that it's measured. Taking an equity lens to level the playing field so that we're making sure that there is equitable access. Balancing donor equity issues with patient safety. We've talked a lot about in this group, certainly about blood donation, and also being aligned with other organizations, authorities, countries, etc., knowing where we're at, checking ourselves against. The next question was, what are some implications of prioritizing inclusion in healthcare for patients, donors, family members, and across the workforce? So we talked about more people getting the best possible match, so health outcomes. And from an equity perspective, putting things in place to address inequities, recognizing the trust in the system is lacking and understanding why that is valid and exists for many people and how to address that. Not having to prove your worth before accessing care. We talked about various people who have had recent, so we're not, we talk about racism in the healthcare system. We're not just talking about the past. We're talking about current examples of friends going to emergency rooms in crisis. And instead of their kidney being treated, being first asked about alcohol. Knowledge, oh boy, knowledge amongst other groups and the ripple effect. We talked about sensitivity training, cultural changes that lead to inclusion from a young age, so that you are learning about equity and inclusion and diversity from the start, and then you don't have to unlearn stereotypes later. The third question, based on your view, is inclusion currently a priority in healthcare? Why or why not? So we put depends on the setting. It's not a priority in all places. There are different standard practices, cultures, and opportunities and capacity for growth and change. This group, we think that change is happening. We didn't discuss if we think it's happening fast enough or not. And approaches should be woven into education from early on. Final question was, Do you believe it is the duty of healthcare providers and members of our field to advance inclusion? And in all caps, we wrote yes. Thanks, everyone.
As a follow, that's fantastic discussion. It's really a phenomenal work. As a follow-up to the all caps, yes. I guess the next question is sort of how, and that will sort of be answered by some of the other groups, some of their themes, but really great thoughts in your discussion. Was there anything surprising about inclusion that, or new information that was shared sort of from one group member to another? It doesn't have to be from yourself, anyone in the group. What are some things that, other people said that surprised you or that helped reflect in a new way on the topic?
I mentioned was as a transplant recipient myself, I checked my blood work and I noticed that there was the difference for EGFR. And so we were continuously taking photos of my lab work and tweeting about it, that this was still on my life labs, even though it had been said that it was going to be taken down. So that was just surprising to me that that was even still a thing as early as last year. And so that has changed now. When I check my work, it's no longer there, which is great. But seeing it here and just that added layer of putting that there, that somebody has to think about that and see that every time that they look at their blood work. It was just pretty upsetting that was so current, like Heather said, that it's not things. It's systematic racism and been happening in the past. It's still happening today. And what can we do? Either it's part of the community of transplant, or if we're working in the field, what can we do to use our networks and use our power to change?
Phenomenal observation that even though change could be prioritized, say at a transplant center level, not to use those discriminatory measures at the level of life lab, etc. Maybe it's not as much of a priority, and it just gets blocked. And so and there are consequences to that too. So really phenomenal observation. For the sake of time, thank you so much, Stuart. It's a theme one representatives, very good. So who had theme two, the recognizing discrimination theme? A few groups. So could maybe one of the group members who's comfortable to share some of the learnings from the questions that were asked?
Oh,
yes.
Okay.
Go ahead.
Great. So the first question, how do you think the discriminatory policies or practices came to be? And reflecting on some discriminatory policies. So we talked about how painkillers often in the US get prescribed mostly to white men and white women because their pain is more believable and oftentimes. We also talked about the discriminatory alcohol abstinence rule that was kind of overturned, but then still makes its way into practices. We talked about the GFR calculations and this kind of sense of objectivity and presumed objectivity that becomes divorced from it as a still perspective and how it still is on lab reports, even though it, some centers say that they don't use GFR calculations anymore. We also talked about the sodium melt scores and how sometimes they can underestimate how sick the person is. And that's some exception points get added on, but then they're not taken into account for the waiting lists. We talked about also Indigenous patients and community members who have to come into more city centers for hemodialysis and have to leave their homes and reserves just to access care because there's no clinics or care on site. And this adds additional layers of marginalization and isolation. And this turned into a conversation about kind of whose pain gets rationalized and how policy makes sense of various perspectives and whose perspective is being shown in policy, often a professional system perspective. And so for question two, what do you think the impact has been on marginalized people? We talked about the mistrust and the layers of mistrust that kind of compound for folks who are more marginalized or BIPOC people who can't access care or aren't, whose pain is not taken at the same level as others. And yeah, does anyone know that?
It's a really phenomenal list and really strong discussions. You know, I have a relevant anecdote to share from our focus groups that we conducted with medical students. One of the students said something that was really interesting. He said, you know, we talk about racism and systemic racism all the time. And if you ask any medical student, is there systemic racism today? They'll be like, yes, there's systemic racism. And then you say, list 10 examples, they'll sort of stare blankly and they'll come up with one or two. But like in the modules, we cover a lot of examples. Were there examples? You created a long list in your list right there. Were there examples that you shared in your group today that others in your group maybe hadn't thought of before, or that you know, it's like, oh wow, I hadn't thought of it like that before, or sort of were there topics that came up that were just, was there new information shared in the group, or was the group familiar with these examples that you shared? I wonder if you or others in the group could speak to that concept. And I mean, this is a different setting. This is a like much more experienced cohort than a group of medical students, for example. So everyone here has years of experience and practice. But oh, go ahead.
So we didn't necessarily have a unique example. What sadly we had was examples that were systemic, like how so many of us know an Indigenous person who went to the ER and then faced questions about alcohol use rather than addressing what was clearly an urgent medical issue. So unfortunately, that wasn't a unique story. Like it's so systemic that many of us knew examples.
Devastating, but helpful to discuss. Yeah, so let's move on to the next theme for the sake of time. So theme 3 is understanding barriers to change. Who had that theme? Theme 3. Okay, sure.
Okay, so we're going to be very high level. We had a very general discussion. So I'm going to try and pull the pieces of it from so it's understanding barriers to change. We're talking about addressing and overturning, identifying harms, and who's responsible. So I'm going to try and do this. Our overview of our discussion upon reflection is more like a socio-ecological model. I'm going to bring it through you from like individual to system change, if that makes sense. But perfectly. So at the individual level, the harm is that there's needed willingness to get involved in the community standards because there is mistrust. So building trust within the community as well, but at the individual level is going to be really important in understanding the barriers. And then once trust is built and relationships are there, finding advocates and champions willing to get involved and moving this forward and bringing out awareness through a variety of mediums. Next would be at the community level. And again, that is like bringing it increased awareness and then identifying stakeholders. So people with more power to be able to share their platforms, as well as like we looked at institutional transplant centers and potentially continuing to monitor data and assess and continue to bring that forward. And gathering other transplant centers to do the same to support if the evidence is reflective or if things are changing and patterns changing. There's a talk about AI being involved in identifying the harms and barriers and proof to change in policy. So, but then there's a question of who builds that AI system because there's bias in that. So part of it is like identifying and reducing bias in general. And then at the policy project, partnerships. So again, the funding, who has the funding, who has control, again, the power and to be able to support these projects and raising awareness and changing. And then at the policy level, gathering the change in the advocates of all of that system together, collectively putting it in front of policymakers and decision makers to make those decisions.
Thank you so much. I mean, you described eloquently from the level of the individual all the way through to the level of the organizational, the kinds of barriers that can be. What else, do you have anything else to add, or what your discussion with the other group during understanding barriers to change?
Yeah, so we mostly went through the governance and leadership issues. So one of the biggest problems we identify was governance, the inertia, and we saw it was showing problem and policy in place. Another big barrier we identified was that most people are unsure of the past things like the problem is that there's no safeness, you just don't know what to do. And then what is the most suitable to do such effort? We think that every person or individual should be involved to create a culture and change the cycle, because we will need to address the problem and create a stable community, not just around the election or any people in place. So we need a stable community to be able to maintain this culture and then put it in place. Moves your responsibilities to conduct such work and beyond overtraining and discriminatory policy, what work needs to be done. We should start by acknowledging it. It's a pretty good start because it's not everybody that are aware of that. And for people, just like the other group said, willingness is nursing, so we need to know what to work and move forward. And finally, the barriers to change and impacting specific on the circle and marginalized population would be proceeding with common stereotypes.
That really helped us understand. For the groups that discussed this, or even opening up to everyone else, there's a lot of lived experience in this room, again, as practicing providers with patients, etc. Was there experience of encountering barriers to change on a personal level or professional level that was discussed in the groups? Did this topic come up going against a machine of a hospital network or a healthcare system to try and encounter change? Something that came up in the groups. Something that you have experienced, I suppose, in your personal lives or in your professional lives, the difficulty of changing policies. Someone speak to the back.
Yeah, always has put up. This stuff I'm using.
Yeah, sorry. So I had a heart transplant in actually it was 2012, December 2012, so it's been almost 11 years. But before I got there, about 17 years I started deteriorating health. And I was doing a lot of research on my particular condition because that's quite specific to the North Poland and et cetera. So I kept track of all the various things that are out there. So there was a procedure that I needed. I've been paced on the right side of my heart for about 15 years. And that caused some problems on the left side of my heart because it was usually the synchrony there. So I read about 5 kids were pacing. Long story, I wanted to get that done. So they weren't funding that at the time, which was general. But okay, how am I going to get around this? And did a couple of things. One is I put together basically a business case. I said to everyone at Toronto General, everybody from the people holding purse strings to the people in charge of cardiology, etc. And I put 7 or 8 points in that business case as to why it made sense for Toronto General to move forward with this particular procedure. And meanwhile, I had a friend who also was a cardiologist. He said, talk to other hospitals. I ended up speaking to Newmarket Hospital. They had some new doctors, Cleveland Clinic. How made a deal with that? So they set up the procedure. So I went up there, but before I got up there, I set up the appointment. Toronto General called. Said, hey, you know what? We've had some discussions on and on. We're going to get some funding. we'll go ahead and give you that procedure. I said, it's too late. I already have an appointment of the new market. You know, so this was me trying to stay alive. And I'm doing this as an individual. So I can imagine what it's like to change everybody in this room as clinicians and patients trying to survive within that medical system by moving to the mountains. I see Sherry, she's done this. It's not easy. And the problem is when you have access issues, minority groups, less disadvantaged people, it's impossible. So again, the challenge is moving from what I say is research, a research paper or 20 of them that have been done from guidance to the patient, to actually getting someone to change procedure in the hospital so you can live. So to me, I'm sure others can experience this. It's not easy.
So thank you so much for sharing. I want to move on to the 6 times the team forward. Now, I know we have a virtual group also, and I don't want to neglect the virtual groups. And so is it possible to get a representative from the virtual group to share their summary of the discussions related to team 4, which is highlighting the need to address disparities in collaboration with advocates?
No, we look.
We hear speaking on behalf of our virtual. Okay, perfect. So one of our first questions was, what do you think of partnering with community advocates to address disparities in how this happened, with some things that come to mind? And amongst our group, was really easy to reflect that, be flexible, to understand that quite often community organizations are including a lot of asks, right? So be mindful, understand their needs, but also understand their limits. You need to understand what their process is when seeking feedback and how we can perhaps co-develop some of that process together. So it's not us as research community that we can know that this is it's going to be. Do your homework beforehand and come prepared. Know what their mission is, know what their values are, know what their priorities are. In front of that, us not going in there, let them know what's, make it our priorities there. We have to be aware of their culture and ensure that the feedback is appropriate. We need to ensure that they don't feel like they're subjects that come up there just so we can collect information and data from them. They are part of the whole process. And also understanding, more broadly, what some of those key cultural needs are. So, for example, as an interpreter, as another community has to consider language barriers, what's the capacity to support the perspectives of folks who might not speak English and want to participate. Also consider how invitations to join or to get people are extended, and consider us going to them, not asking them from us. Next question, what are some ways that collaborating with advocates can help address disparities? Well, they can have an impact on the direction of the wording of the question, for example. We can tap into pockets of community members that we wouldn't thought otherwise. Who are the influencers? Who are the leaders in the community? How can we partner with them so we can, whatever our goals are, make sure that that is something that happens. It helps us understand. It helps us understand what their needs are. There's better to tell us that themselves, and we try to understand what's in the barriers and disparities of experience also. We need to understand what the barriers are to engagement and develop strategies to support the engagement. So, for example, some examples that give us what we talked about was internet or tech issues. How can we better facilitate that conversation with childcare, application, as some examples. Ensuring that research projects also include materials are reflective of their experience and that the methods of receiving information are appropriate. Again, making it relevant to them, making sure that the uptake is supported. How can such partnerships overcome barriers impacting patients or donors? So developing partnerships really speaks to we can develop meaningful relationships, develop building trust in that process for co-development, not us talking them. How to do things for what we choose are. Spoke about this already, but culturally sensitive materials. We've been partnering with some of these pieces. What special considerations are relevant when collaborating with advocates for marginalized groups? Understanding that there may be real or perceived power imbalances and the way that we communicate and develop these processes is reflected in the genre of the book. There needs to be a strong sense of trust between us, the research community, and patients and donors. And also recognizing from perhaps a little bit more practical aspect is recognizing that in order for donors or patients to receive medical attention and come out to needs them to come into a city, for example, outside their comfort zone, whether it's physical and that stuff. How can we make that a little bit easier for them? Final question, what are some necessary steps to be taken prior to seeking collaboration? We talked about this a little bit, but doing homework, submission, project, really to avoid tokenism and be mindful of resources. How we support that.
Fantastic, was really thorough. And I mean, you bring up really interesting points that sort of a crossroad here where we're trying to advocate in collaboration with advocates from diverse communities. And that puts the principle sort of nothing about it without us. You can't understand our needs without working with us. But on the other hand, it's like there are also considerations such as if you badger or you work too much with advocates from the same groups, you can exhaust them, they have limited bandwidth. And then there are all these other considerations that your group brought up as well related to, okay, there are just interests, there's need, but there are socioeconomic barriers, there are language barriers, there are other barriers that can interfere with that research disparity. And I mean, I know the inpatient group I was participating in some of the discussions after here. I know that some of these concepts as well. For the sake of time, I want to move on to the theme 5 before we wrap up with the final comments. So which were the groups that had theme 5, creating the culture to support inclusion? No one was discussing theme 5? Okay, that's okay. Okay, that's fine. Yeah, so then, so for theme 4, sorry, which group is this? Okay, okay, sure.
So, for theme 4, highlighting the need to address disparity in collaboration with advocates. So I'll just sum up very briefly about our discussion. I think the first key thing that we all agreed on was it's important because you come to know more about your population. If you have to, you cannot address it without having someone from that population. Second thing was it will help us to diversify our perspective. You cannot think about their perspective without having a member of the community. Okay? Third is and the biggest thing that we all agreed on was the barriers that they face. Just to know the barriers that they face, or even facilitators would be important so that you can help them in longer term. Last thing that we all agreed on was what consultations we need to collaborate with advocates from marginalized groups. Financial, culture, not everyone will be available all the time if they have prior commitments or other comorbidities. And also it gives them a sense of belonging that they are talking and doing something for people they care about. And I think that really helps them to say or put their story out there and help other people.
Wonderful. Really powerful insights. Thank you. And then there was another group I think we had missed too. Was that in person or virtual? So that's wonderful. So then, since we didn't have a group focusing on the 5 creating a culture of support inclusion, I actually think this is a perfect theme. This is a perfect theme to discuss as a group together. We actually all have to build a culture of inclusion together. So I asked actually those who were interested to participate or to share their thoughts. What does the culture of inclusion look like to you? What is it that we can do to build one or advance one together?
CDTRP.
What does a culture of inclusion look like to you? Like, how can we advance a culture of inclusion together? At the individual level, in our organizations, in our field? I see someone raising their hand.
I think it has to start in the education system at a very early age. Because for people that are older and have their biases deeply ingrained, it's a lost cause. But, so I think we just start over at the elementary level.
Hopefully that doesn't include this group.
No, those that have their biases, 15th grade.
No, it's a fair point that you should not target interventions at the very end of this type of practice, but all the way through the healthcare system, it should be part of the curriculum, it should be of value. I see someone raising their hand over here.
I'll give you last, that's okay.
Look for the virtual library too.
One of my friends once told me about a situation where she was at a conference and had mentioned that there was no Indigenous partners, and this person said to her, "Oh, well, then you better get to work and make sure that there are." And you know, it was just such a shocking comment, and so stop expecting people to have to do that work to take in that door. And if you're in a position of power to open that door and to ask why those people aren't sitting at the table as well, because we have so much power in our individual circles. So use that to make sure that voices are heard from all of the communities.
Phenomenal insights all. Someone else raising their hand in the back.
And that's that. So I think we need to look around at our tables because like it's the same way that patient partners feel, right? You go and you were the only one there, right? And so exactly everyone who's done any work on how to engage with Indigenous people know that it's nation. So we're being asked to get like as you know, get an Indigenous person to chat or get someone from a different community to chat. But if we're really going to do this properly, we need to do it with communities. And we also want to find out how they want to be included, right? Like in the South Asian community, we did a lot of work on organization. It's the elders, right, that you have to go to get permission, right? And different like cultures have different ways of doing it. So I think we need to know how to do that. And I don't think any patient should be expected to cover everything. And that is something that is being done.
I think the other thing is that communication is big, as much as, you know, the most important things that we listen well, but without the ability to communicate in different languages, with a translator, without like translated material, it's hard to do that. So I think that there needs to be like a willingness and an openness to look at those mechanisms so we can all communicate together. And that's
Really strong insights.
And if we're doing inclusion as well, like we need to look like yesterday and the day before was World Day of Disability. You know, a lot of things about people who are patients, they have only like someone, right? But we also need to look at where were things acceptable, right? And then also what time we're hosting as well to make sure that that opens up for everyone, right?
Really strong insight. Any other final thoughts moving through before we wrap up?
One small one, and this is for you, Manuel and Sylvia, and I see a lot of great openness and closer proximity with patient partners. How does research and CDTRP or community can help researchers reaching for cultural, gender, and all those people that are reached to, hard to reach, and how can we improve it? You don't have the answer. If you don't have the answer, you're okay, but there's so many researchers here, they need to know that specifically.
Thank you. These questions, these themes are not with easy answers. I think the discussion is really helpful and the learning is really helpful. And their career-long projects to address each is an understatement. But I think some really fantastic discussions here by everyone and really strong. So thank you all for your engagement and participation. It's been really meaningful.